Shall I start my presentation?
Just a minute, sir. Yeah, so we are already live. Now, with all your due permission, we are beginning with the session for today. Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Well, sir needs no introduction at our platform, but it's my pleasure and honor to introduce him. He is none other than the very renowned endocrinologist, Dr. Abhyuday Verma, sir. Sir is Associate Professor at the Department of Endocrinology, Index Medical College and Research Institute, Indore, MP. So with the help of sir, we'll be taking a close look on today's topic, which is amenorrhea, endocrine disorder. Before moving on to today's session, let us have a brief look on what the topic says. Amenorrhea, a significant endocrine disorder, refers to the absence of menstrual periods in women of reproductive age. It can result from various underlying hormonal imbalances, structural abnormalities, or lifestyle factors, warranting comprehensive evaluation and specialized management. We'll be learning and we will understand the complexities of this condition by sir's appropriate information that he's going to provide to us, and with appropriate care and support to affected individuals, how we can understand the complexities. So now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you, madam. Thank you for the kind words, and thank you, team IJCP, for giving me an opportunity to talk on the topic amenorrhea, which is quite commonly seen nowadays, not only in elderly females as we used to think earlier, but a lot of young females now, a lot of teenagers, they are facing problems of irregular menses and amenorrhea also in between. Amenorrhea can be a problem in itself, as we will see in my coming presentation, or this could be an indicator of underlying problems in the body, especially the endocrine dysfunctions. So I would be talking briefly about both the primary and the secondary amenorrhea, but mostly I will try to restrict my presentations to primary causes of amenorrhea, and we will see that what are the causes, what are the evaluation, and some of the management part. So to begin with, as we have already seen and heard, what is amenorrhea? Amenorrhea is basically absence of menses. And as I told, that this could be transient, maybe for a smaller duration, or intermittent, the waxing and waning. It's like sometimes menses they come, sometimes they are not there, or it could be permanent also, depending upon the abnormalities. And the abnormalities can be at the whole hypothalamic gonadal axis, hypothalamic pituitary gonadal axis, starting from hypothalamus, pituitary, ovaries, uterus, or vagina, where here we have a combination of either an anatomical problem, an obstruction, or it could be a hormonal dysfunction also. Then the amenorrhea is classified either as a primary or a secondary amenorrhea. And primary is basically at the higher centers, mostly what we say the pituitary and the hypothalamus. And one more definition which is commonly used for primary and secondary are the primary when it is quite early, or the absence of menarche by age of 15 or thereafter. So if somebody doesn't get menses by age of 15 or above, then we say that it is a primary amenorrhea. Secondary may be absence of more than 3 months in a girl or women who previously had regular menstrual cycles. So this is any time in the reproductive age group. If 3 months, no menses, then we say this is a secondary amenorrhea. Or 6 months in girls or women who had irregular menses. As I said, some people, they may have intermittent also. So here we say that yes, if they had menses, but they were quite irregular, unpredictable timings, then we can have amenorrhea as 6 months, no menses, to label it as secondary amenorrhea. Now coming to evaluation, that who should be evaluated. So obviously we have seen primary, secondary. Obviously this is one criteria. Another criteria is by age 13, if in a girl you don't see menses and there is no development of secondary sexual characters also, we should not wait further, because we already know that normally nowadays by age of 10 to 11, a lot of females, they start getting at least secondary sexual characters. So by age 13 also, if a female doesn't have any secondary sexual characters and no menses, definitely we should not wait till 15 years, which I showed you in the earlier slide. So this is also important. And girls with secondary sexual characteristics, they may present before 15 years with amenorrhea and cyclical pelvic pain. So these, see, different things are really important. It's not only one cutoff age we say, it's not only the secondary sexual characters we say, there are other things also which we should keep in mind according to the normal physiology of pubertal development. And if we see any deviation from these, definitely we should not wait for at least evaluation. When we come to the causes, these are some of the commonest causes. I have not included rare causes, but this is generalized cause just for a better understanding. So maximum cause of primary amenorrhea, again I would repeat here, most of my causes and the talk I would be trying to concentrate on primary only, and secondary if there is a overlap of primary and secondary. So primary amenorrhea, the commonest cause is gonadal dysgenesis, especially Turner's syndrome, and it constitutes about 43%. So this is very important. Girl, no secondary sexual characters, 13 years of age, along with Turner stigma, definitely should be evaluated for Turners, because this is the commonest. You can see almost 40%, or you can say almost near to half of the females may have Turners, and it should be evaluated along with other hormonal and structural abnormalities also. Then we have Mullerian agenesis. 15%, where there is absence of vagina with or without uterus also. Then we have physiological delay of puberty, about 14%, constitutional delay, or sorry, there was some problem with my technical problem, I think. Something. So we'll start again. Hope I am visible. So here we see the main cause. You can see if we just keep in our mind these 3-4 causes only, we would be very accurate in our diagnosis of primary amenorrhea, and this will help our management. Then we have other rare causes like isolated gonadotropin releasing hormone or GnRH deficiency, 5%, transverse vaginal septum in 3%, weight loss or anorexia nervosa 2%, and hypopituitarism 2%. So these are some of the commonest causes of the primary amenorrhea or amenorrhea. These commonest causes, I won't go in detail, but yes, for it, hymen should also be considered, complete androgen insensitivity syndrome, where the person is a born XY, but then there is complete androgen insensitivity. So we may have characters like a female, but basically he or she is a XY. Then we have hyperprolactinemia or prolactinoma, pituitary tumors causing again maybe hypopituitarism, congenital adrenal hyperplasia, hypothyroidism, various CNS defects, craniopharyngioma, Cushing's, and now a very common thing, but quite often forgotten, the pelvic tuberculosis also should be considered. Now approach, how we should be approaching our patients. So now we know what are at least the commonest causes. We know the age when we should try thinking and start our approach to these type of females. Presence or absence of breast development. So this is important. We have to take into consideration all the physiological stages of puberty, whether they are happening at proper time, proper sequence or not, and anatomical presence or absence of organs, like presence or absence of uterus and a FSH at least. Why FSH? Very important. FSH, because if the FSH is high, we may think of gonadal dysgenesis. Maybe again, common is Turner's. So we should get a karyotype. If SH is normal, but the sonography says uterus is also absent along with normal testosterone. Why we have to think about testosterone here? Because this could be a 46XY complete androgen insensitivity. But If testosterone is normal, we should think of second commonest problem, the Mullerian agenesis. But if testosterone is in range of a male, testes are present, uterus is absent, then we can start the workup for androgen insensitivity, complete androgen insensitivity syndrome. If FSH is normal, breast development is normal, and uterus is also there, but on sonography shows accumulated blood either in the uterus or vagina, then it may be just a case of anatomical defect like obstructed outflow tract. And if FSH is low or normal and the uterus is present, then it could be a constitutional delay of puberty or maybe a congenital GnRH deficiency also. This we can follow up regularly and see. So this should be a very simple. This is basically a very simplified approach, just the presence absence of breast, uterus, and on FSH we can categorize the commonest problems seen causing amenorrhea. And now history. This also gives us a lot of informations, like has she completed other stages of puberty or not? How was the growth spurt, development of axillary and pubic hair, and was the puberty count seriously? Family history of delayed or absent puberty. Height as per parents, neonatal and child health. How was the history? Any symptom of hyperandrogenism? Any stress, change in weight, diet, exercise, or illness in recent past? Any drug history, galactorrhea, headache, visual field defects, fatigue, polyuria, polydipsia. These are very simple to take, easy to recall also for patients. This history is very important. Physical examination, obviously. Anything, any diagnosis of amenorrhea or hormonal imbalance should include a thorough physical examination, which includes an ultrasound also. Yeah. So in ultrasound or MRI, we should confirm that uterus, vagina, cervix are there or not, or absent. The breast development, the height, weight, and arm span of the child. Skin, whether we have acanthosis, acne, hirsutism, increased pigmentation, vitiligo, etc. Then physical features of Turner syndrome, and obviously a careful genital examination. Lab tests, we all know, but yes, these are some of the important lab tests. The HCG, FSH, prolactin, TSH, and if required, we may go for free T4 and estradiol also. And if we have confirmed with the physical examination in USG, if uterus is present, then again for Turner's, we should go for chromosomal abnormalities causing gonadal dysgenesis. Then obviously the breast development, and watch for other anatomic abnormalities also. If we have high FSH, which can be seen in premature ovarian insufficiency also, again karyotype is important, and other problems also. should be considered. If at least we are taking Turner's syndrome, congenital heart disease, hypertension, hearing loss, or additional autoimmune diseases. And again, I have told earlier also, but here we'll see again, if there is a low or normal FSH, it could be a central hypothalamic pituitary problem. It could be a outflow tract disorder or an endocrine disorder. So girls with normal breast development may either have anatomical abnormality or PCOS, hyperprolactinemia, and thyroid disorders, which can give us low or normal FSH. Approximately 15% of females, as I have already told earlier, with primary amenorrhea may have anatomic abnormalities. We should check for signs and symptoms of hyperandrogenism also, and go for lab investigations, testo and DHES. If there is no breast development, we should consider the central hypothalamic pituitary disorder also, because there is no gonadotropin which can stimulate the pubertal changes, like maybe congenital GnRH deficiency, constitutional delay in puberty also, where there is a late starting of GnRH generator, or other anatomical disease also, especially of CNS, which can hamper a normal GnRH secretion. Or nowadays we commonly see the functional or hypothalamic amenorrhea also, due to various eating disorders, excessive exercise, or stress or systemic illnesses also. If uterus is absent, again, as I said earlier also, it could be confirmed only if we get karyotyping and total testosterone. If we have 46XX, it could be abnormal complete androgen insensitivity syndrome, or we can see a severe virilization at the time of puberty due to 5-alpha reductase deficiency. So in short, the management, obviously, it is treating the underlying pathology, helping the female achieve fertility, and preventing further complications. All patients should be counseled regarding proper cause. They should know what is the cause, what are the potential treatments, and the chances of reproduction. Along with this, a psychological counseling for both the child and the parents also, especially in presence of Mullerian, absence of Mullerian structures or a Y chromosome. And obviously surgery for congenital anatomic abnormalities or a Y chromosome material. We may have to go for vaginal outlet corrections or a neovagina construction. And if there is a Y chromosome, then the chances of gonadal neoplasia are there. So we might have to go for gonadectomy, but it could be slightly delayed in patients with complete androgen insensitivity syndrome till the puberty happens. For premature ovarian insufficiency, we have to think of giving them the hormonal replacement therapy. We have to discuss with them the cardiac and bone health because of the hormonal deficiency. And in females with PCOS, we have to explain them about the benefits of the hormonal therapy for regular menses, for reduction in hirsutism, and the long-term consequences or benefits of regularizing the menses with the hormonal therapy. And in functional amenorrheas, female who have lost a lot of weight because of various reasons, we should advise them weight gain, reduction in the intensity of exercise, resolution of illness or emotional stress should be done at earliest. And if they do not want or desire fertility, then we may start them on E plus B combined therapy, or if they want fertility, we have to go for exogenous gonadotropin or pulsatile GnRH therapy. The last, obviously, assisted reproductive techniques can be done for Turner's, donor oocyte, and IVF also can be done if patient has got her own uterus. But if there is absent uterus, we know with own oocytes in IVF and embryo transfer can be done to another gestational carrier. Thank you.
Thank you so much, sir. Thank you for the presentation that you have pondered upon today with all your views. We have received few questions. I would like to put it across to you.
Yes, yes.
The first question is, how prevalent are anatomic disorder and high prolactin level etiologies in secondary amenorrhea?
Actually, they are quite common, especially prolactin. As I said earlier, also I had mostly concentrated on the primary amenorrhea, but yes, hyperprolactinemia is also now seen quite a common cause of secondary amenorrhea because of a lot of patients taking psychiatric medicines which increase the level of prolactin, even our routine PPIs can also increase the level of prolactin. So there are quite known common drugs which may increase prolactin levels and can cause secondary amenorrhea. Okay, so any other questions we have? So we have how long-term monitoring is required following treatment of amenorrhea. So see, this is basically it all depends on the cause. See if it's like a cause where hypothalamus pituitary is damaged, or there is a kind of hypopituitarism. So these patients may require a long-term or maybe a lifelong therapy. And if it is like gonadal dysgenesis also, then also they require a lifelong therapy. Only some cases like the anatomical defects and all, where we have to just correct the anatomical problem and follow up regularly so that the reconstructed vagina or the repair of vagina is all okay. So I think most of the causes, especially primary causes, they require long-term treatment, especially the gonadal dysgenesis and the pituitary and hypothalamic causes. But yes, secondary amenorrhea causes like hyperprolactinemia, PCOS, or maybe like hypothyroidism, or any kind of chronic illness. These things, if they are managed well, then definitely they don't require a long-term follow-up also. Yes, a good question. That what should be the focus of patients' history in women with secondary amenorrhea? So again, I would say, as I told in my earlier answer, that we should take care of the concurrent medications which patients are taking, because a lot of drugs nowadays, they have interfered with normal hormonal changes in persons. A lot of, as I said, normal the PPIs, antipsychotic medications, chronic illness, and any family history also of early amenorrhea, which may cause premature ovarian insufficiency, or any chromosomal abnormalities, because a lot of females with Turners, they may have initial a couple of years of normal menses, then irregular menses and oligomenorrhea, and maybe after 10 years or so of the menarche, they may have kind of secondary amenorrhea, depending upon their ovarian reserve. So physical examination is very important, and the overall history of the pubertal development, the physical examination, the drug history, all are important.
Thank you so much, sir. Thank you for answering that question. We'll take the next question and the last question for today's session. And the question is, what are the underlying etiologies of hypergonadotrophic hypogonadism amenorrhea?
See, basically, it's the ovarian. For hypergonadotropic, definitely it's the gonadal. So whenever we see high FSH levels and the LH levels, but basically the FSH level, we should be thinking more of gonadal dysgenesis.
Thank you so much, sir. Thank you for answering the question. That was the last question for today's session. And at the outset, I would like to thank all the viewers who were here with us and had put across these questions to us throughout the session. So thank you to all of them for their ardent participation. And with this, I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful inputs with all our viewers. So with all your last comments, sir, we can conclude the session here for today.
So my last just comment that for amenorrhea, a good history and physical examination is always important. So don't rely only on laboratory investigations. Go for a good history and physical examination. With this, I like to end and thank the team IJCP